Pakistan Physiology of Pakistan Physiological Society and Azad Jammu Kashmir Medical College Muzaffarabad, Women Medical College Ahmedabad, and Pakistan Association of Pathologists. And from the last 2 years, we are almost covering very, very important topics. And this program we started with COVID, and still we are on this webinar. We are covering different topics of different aspects of life. And today's, with the help of Professor Salma Kundi, who is principal of Women Medical College, Ahmedabad, and president of PMA, we are now able to start 44th webinar. And today's topic is a very, very important topic. NAFLD, a silent killer. And two youngest my consultants, मैं तो इनको प्रोफेसर ही कहता हूँ, अल्लाह इनको प्रोफेसर ही करे, Dr. Rahman and Dr. Rubina Rafiq, and excellent consultants, excellent physicians. Dr. Numan did his MBBS from Ahmedabad. Almost, I think he would be a student of Professor Ayub in 2004. And then he did FCPS 2014, almost 5 to 8 publications, and so many workshops, seminars, national and international societies. He is also a very, very active leader of, I will say him, leader of Pakistan Society of Hepatology. Almost, I am proud of all this team who did a very lot of welfare and a lot of precious work during the COVID. Dr. Rubina is excellent consultant, mashallah, and both are working in the AIMS. And Dr. Rubina is a general physician, while Dr. Naman Karim Qureshi is a gastroenterologist. Professor Naman, before I give the mic to you, over to you, I will request Professor Rashid Saab to start, before starting this webinar, recite a few verses of Holy Quran. Over to you, Professor Rashid Saab.
Jazakallah, Professor Mohammed Saab. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم كتب عليكم القتال وهو كره لكم وعسى أن تكرهوا شيئا وهو خير لكم وعسى أن تحبوا شيئا وهو شر لكم والله يعلم وأنتم لا تعلمون صدق الله العظيम। इस सूरतुल बकरा आयत 216 का मफहूम तर्जुमा है, मुसलमानों तुम पर खुदा के रास्ते में लड़ना फर्ज कर दिया गया है। वो तुम्हें नागवार तो होगा, मगर अजब नहीं कि एक चीज तुमको बुरी लगे और वो तुम्हारे हक में भली हो, और अजब नहीं कि एक चीज तुमको भली लगे और वो तुम्हारे लिए मुज़िर हो। इन बातों को खुदा ही बेहतर जानता है और तुम नहीं जानते। वाखिरु दावाना अल्हम्दुलिल्लाहि रब्बिल आलमीन। जज़ाकल्लाह।
Thank you, sir. Welcome all, the faculty of AJKMC, the precious students and the worthy members of all societies. Assalamu alaikum. Before starting this, आई प्रे फ्रॉम अल्लाह कि आजकल जो हमारा सैलाब से और इस तरह के जो डिसास्टर से वी आर फेसिंग, जस्ट वी आर फ्रॉम द लास्ट वी आर फेसिंग द कोविड, और इसके बाद अब ये सैलाब है। तो इससे इस सिलसिले में मुख्तलिफ लोग मुख्तलिफ तरीके से जिस तरीके से भी मदद कर सकते हैं इसको मिसाल आपको दूं, जब अल्लाह के रसूल सल्लल्लाहु अलैहि वसल्लम मक्का से मदीना गए, तो आज हम हेल्प किस तरह कर सकते हैं, मिसाल मदीना ज़रूर अपना सकते हैं कि एक एक फैमिली, एक एक इंसान अगर एक एक फैमिली को अपना ले तो ऑलमोस्ट अगर 3 करोड़ जो पीपल्स आर अफेक्टेड एंड हम 22 करोड़ हैं, वी कैन इजीली हेल्प द पाकिस्तान। सेल्फ हेल्प बेस के ऊपर हमें पाकिस्तान को बनाना है, पाकिस्तान हमारा कंट्री, इंशाल्लाह हमारी इस काविश से अल्लाह ताला भी हम पे रहम फरमाएगा। दूसरी, बिफोर स्टार्टिंग दिस, आज़ाद जम्मू कश्मीर मेडिकल कॉलेज is hosting sixth our international symposium, और वो है 14, 15, 16 3 तारीख को। इनागुरल सेशन will be on the 14th September. I will welcome you, my team will welcome you all there। और उससे पहले मुख्तलिफ अपनी प्री कॉन्फ्रेंस वर्कशॉप्स हैं, and we will welcome all the members of the Pakistan and Kashmir to attend this. Now we start this webinar. Now it is over to you, Dr. Numan Kareem Qureshi.
Assalamu alaikum everyone. Thank you, sir, for such a nice introduction. I am Dr. Numan Kareem Qureshi, currently working as a head of department of gastroenterology and hepatology in CMH Muzaffarabad. Before starting my presentation, I would like to say thanks to Principal Azad Jammu and Kashmir Medical College, Professor Mulazim Hussain Bukhari, for inviting me and giving me opportunity to talk on this forum. To start with, let's start with a scenario. I think it's a common scenario. Most of us almost deal with this type of scenario. A 35-year-old male, which was obese and with ALT elevation and fatty liver. So a patient referred by a general practitioner for mildly raised ALT and ST.
जरा आगे हो जाए, आवाज कम आ रही है। जी जी,
अब ठीक आ रही है सर?
अब ठीक है।
Patient had ALT of 70 and AST of 63. Other liver tests were normal and he was not on any medicine. For medical history, his mother was diabetic. His examination showed normal blood pressure, but he was obese with BMI of 31. There was no stigmata of cirrhosis, but liver was palpable 3 centimeters below the right capsule margin. Splenomegaly was not there. Rest of the examination was normal. His ultrasound was done, which showed liver size was 17 centimeters with increased echogenicity. So this was the scenario: a patient with dyslipidemia, diabetes, obesity, and raised ALT and fatty liver. Especially we deal with the patients which do with So I am sure, inshallah, at the end of this session, you will be able to know what to do with these sort of patients. So by definition, non-alcoholic fatty liver disease, it is the presence of hepatic steatosis with or without inflammation and fibrosis, when no other causes for secondary hepatic fat accumulation are present. It is associated with other disorders like components of metabolic syndrome, that is obesity, systemic hypertension, dyslipidemia, insulin resistance, or overt diabetes mellitus. So there was changing of the name from NAFLD to MAFLD for this reason: metabolic dysfunction associated fatty liver disease. So you see NAFLD versus MAFLD. So what is the difference? Basically, non-alcoholic fatty liver disease was the diagnosis of exclusion. Other disorders which can cause fatty liver, they used to be excluded, like hepatitis B, C, alcoholic liver disease. Whereas MAFLD, metabolic dysfunction associated fatty liver disease, in which there were metabolic dysfunctions. It's a positive diagnosis and metabolic risk abnormalities were present, like diabetes, obesity, dyslipidemia. So this is the difference between NAFLD and MAFLD. In MAFLD, metabolic abnormalities play a role. So this is patients which are diagnosed with fatty liver. They have hepatic steatosis, whether through ultrasound or biomarkers or liver histology. If they are overweight or obese with BMI, in Asian population, obesity means BMI of more than 23 kilogram per meter square. So they are labeled as MAFLD, metabolic dysfunction associated fatty liver disease. Again, fatty liver with type 2 diabetes mellitus, according to widely accepted international criteria. So they are again labeled as MAFLD, metabolic dysfunction associated fatty liver disease. There are patients which have fatty liver, but normal weight. So in those patients, if two of the metabolic risk factors are present, then they are labeled as MAFLD. This includes waist circumference, which is more than 90 in Asian men and more than 80 in Asian women, high blood pressure of more than 130 to 85, high plasma triglyceride level of more than 150, low HDL level, pre-diabetes, and HOMA index of insulin resistance of more than 2.5, and raised CRP. So any of two metabolic risk factors in people with fatty liver and normal weight, so they are labeled as MAFLD, metabolic dysfunction associated fatty liver disease. Non-alcoholic fatty liver disease is seen worldwide. It is very common, and it is most common disorder in the Western and developed countries. In a study which was done in US population, NAFLD, non-alcoholic fatty liver disease, was seen by ultrasound in 46% of the population. Among those, 12.2% had NASH, which had NAFLD. In another study which was done according to weight, 94% of obese patients had NAFLD, and 7% of the overweight patients had non-alcoholic fatty liver disease. And surprisingly, 25% of the patients which had normal weight also had NAFLD. In another study which was done in apparently normal liver, in which living liver donors were there, histologically NASH was seen in up to 16 or 15% of the patients. So apparently they were normal, but histologically they had this liver disease. And this incidence increases with weight. This is prevalence of obesity. If more obese people, they have more chances of NAFLD. Like in USA, obesity is very high and prevalence of NAFLD is very high. In Pakistan, almost 25% of the people are overweight with female predominance, and NAFLD is present in 18% of the population. So this is the spectrum of non-alcoholic fatty liver disease. First, there is steatosis, fat accumulation, which means fatty liver. It can change into inflammation like steatohepatitis. When there is inflammation of the liver because of the fat deposition, it is called NASH, non-alcoholic steatohepatitis, which can lead to accumulation of the fibrous tissue, which is called fibrosis. So fibrosis, if mild fibrosis, it is called F1. If more than that, it is F2 and then F3. And when it becomes F4 fibrosis, it is called cirrhosis. And then cirrhosis can lead to complications. So this is fatty liver, which can lead to NASH, hepatitis, or which can lead to fibrosis. So this causes a lot of problems in future. So this is non-alcoholic fatty liver. Fat infiltration may be there of more than 5% with or without mild inflammation. But when there is, so it is associated with necroinflammation like ballooning, Mendry bodies, and mega mitochondria on liver biopsy, it is called NASH, non-alcoholic steatohepatitis. This leads to fibrosis, fibrous tissue deposition in the liver, which causes damage to the liver. And again, cirrhosis and all the complications. So again, F1, no fibrosis, like normal liver. It may change into F1, F2, and F3, and ultimately F4, which becomes cirrhosis. It is the most severe form. It is called silent killer because most patients with non-alcoholic fatty liver disease are asymptomatic. They are diagnosed incidentally. Though some patients have hepatomegaly, which may be the only presenting sign. So the diagnosis of NAFLD requires all of the following. Number one is demonstration of hepatic steatosis by imaging or biopsy. Like patient comes with ultrasound report, sir, I've got this fatty liver. In those patients, exclusion of significant alcohol consumption, exclusion of other causes of hepatic steatosis, we will discuss later, and exclusion of coexisting chronic liver disease. So all these criteria are met, then it is labeled as non-alcoholic fatty liver disease. So how do patients present? They either come with abnormal LFTs, as we had seen in our scenario, ALT of 70 and AST of 63, or they come with abnormal imaging, usually ultrasound, which shows bright liver or increased aquitexture of the liver. So in our patient. So how reliable is ultrasound in diagnosis of NAFLD? Changes consistent with NAFLD may not be detected if less than 20 to 30% of liver contains fat. So more fat deposition can lead to diagnosis of NAFLD on ultrasound. Also, ultrasound findings for fatty liver cannot be distinguished from those of early cirrhosis. Also, ultrasound is operator dependent. So these are the other causes when patient comes with fatty liver and ultrasound. These causes need to be ruled out. So other causes of extra fat in the liver, topmost is alcohol consumption, then malnutrition, then medications like antidepressants, antipsychotics, tamoxifen, and parental nutrition. These need to be ruled out in these cases. Coexisting liver diseases like hepatitis C, hepatitis D, which is definitely with B, then Wilson disease and hemochromatosis. These are infiltrative disorders. All these need to be ruled out to label it as non-alcoholic fatty liver disease. So how to diagnose non-alcoholic fatty liver disease? You see, this ALT is not that sensitive or specific, not a reliable for diagnosis. If patient has just raised ALT and AST, it does not mean patient has NAFLD. Ultrasound is a bit better in diagnosis, inexpensive, accessible, but again, the drawback is it cannot distinguish that it is just fatty liver or this has led to fibrosis. So ultrasound cannot differentiate these. CT again, better in obesity, but affected by iron fibrosis and less accurate with less fat deposition. MRI detects even mild steatosis, quantifies hepatic fat deposition most accurately, but again, very costly. The gold standard is liver biopsy, but again, it is invasive and again, subject to sampling error. So this is ultrasound, which is important for diagnosis of NAFLD, but it cannot differentiate whether this steatosis had led to fibrosis or not. So there was need of some markers or some investigation or test which may be able to diagnose liver fibrosis without liver biopsy. So these are called non-invasive tests for liver stiffness or fibrosis. Ideally, they should be simple, reproducible, less expensive, readily available, and they may predict full spectrum of liver stiffness or fibrosis, and they may reflect changes occurring with therapy, improvement or not. So these are the tests which are there for assessment of fibrosis. Serological tests, which include blood tests like this one is called NAFLD fibrosis score, other one is called EPRI, AST to platelet ratio index. The third one is called fibrosis 4 or FIB4. I think everyone should know these, and they are readily available, and they are very simple and very easy to calculate. The other tests are radiological tests. The most commonly used is transient elastography, which is called FibroScan, then shear wave elastography and MR elastography, which are MRI dependent. So this is again the same thing, simple test, clinical and lab test, EPRI score, FIB4 and NFS, NAFLD fibrosis score. These are not used commonly, and this is vibration controlled transient elastography, again, shear wave elastography and MR elastography. We see what are these tests now. So NAFLD fibrosis score, online calculator is available. You see all the parameters are easily done. Age, BMI, you need impaired fasting glucose, AST, ALT, platelet, albumin. These are all simple tests, cheap tests, and can be done easily in every patient. This is EPRI score, AST to platelet ratio index. Easily can be calculated on a calculator online. Just AST and platelet count are needed. So very simple. You just need two tests and basic tests. FIB4, again, apart from age, you need AST, platelet, and ALT. These are all very simple and cheap tests and readily available. This FIB4, these are the parameters, and it tells you if it is more than 2.67, it is high probability of fibrosis, that's F3, F4. We will discuss later. So these are very simple tests. Everyone should know it. This this EPRI score, FIB4 and NFS. Online calculators are available. So what happens with these non-invasive tests? They exclude or determine advanced fibrosis. Like this, FIB4 is if, less than 1.3 and NFS is less than minus 1.45. It means absent fibrosis or advanced fibrosis. If FIB4 is more than 2.67 and NFS is more than 0.6, it means presence of advanced fibrosis. So it includes and excludes fibrosis very well. So now elastography, three tests we just mentioned. One is transient elastography, which is more commonly available. It is user-friendly, good reproducibility. If you do in follow-up, it will good results, high performance in cirrhosis, but it has drawbacks that it requires a dedicated device. And region of choice is not to be chosen by the operator. Unable to discriminate between intermediate stages of fibrosis, and it can be false positive in cases of cholestasis, acute hepatitis, excess alcohol intake, liver congestion, and food intake. So it has to be on empty stomach and has to be, these hepatitis and cholestasis needs to be ruled out. Shear wave elastography can be implemented on regular ultrasound machine. It also measures liver stiffness in real time, high performance in cirrhosis, but again, it is unable to discriminate between intermediate stages of fibrosis. MR elastography can be implemented on MRI machine, examines the whole liver, high performance for cirrhosis, high applicability for then transient elastography, especially in obese and with ascites. But again, it is time consuming like MRI and is costly. So not available everywhere. So this is again in primary care, availability of these non-invasive and simple tests is there. Like we just mentioned, EPRI score, FIB4, NFS, they are easily available and not very costly. But again, we move to the tests which are elastography, cost increases. Like transient elastography is costly, but MRI is more costly. So we will discuss this FibroScan, transient elastography, which is most commonly used. It tells us fibrosis in kilopascals. For example, if it's measurement in units, if less than 6, it means F0. If it tells that fibrosis is 6 to 8, it means F1 or F2 fibrosis. And if it is between values between 8 and 12, it is bridging fibrosis. And if value is more than 12, it means F4 fibrosis, which means cirrhosis. So it is most reliable in ruling out advanced hepatic fibrosis. Negative predictive value is higher than positive predictive value. Fibrosis unlikely with low values more than 6 and predicts advanced fibrosis if value is more than 12. Higher values increase likelihood of more severe fibrosis, predicts risk of decompensation and complication. But again, we just had seen that in cases of hepatitis, cholestasis, it can have overestimation. Again, correlates well with portal pressure. For example, if score is more than 20 kilopascal, it shows that this patient might be having esophageal varices because of portal hypertension. So this is a method. This is very simple test, easily done. Just a bit training is needed. This is the position of the patient, and this is the area where it is done just like an ultrasound probe. The thing is, it measures this volume which it sees, it 4 centimeter and 1 centimeter. It is 100 times bigger than biopsy sample, the area which it sees. The shear wave elastography has a different mechanism. It assesses fibrosis through shear waves and pressure, compression force. So the usefulness of these in non-invasive tests, if they used a non-invasive test, they could reduce the number of patients and indeterminate zones. Like if one test is used, one non-invasive test is used, it shows this number of patients have advanced fibrosis. This is indeterminate, in which we cannot comment, and in which presence of advanced fibrosis. But if two tests are used, like NFS with EPRI or with FIB4 or with elastography, this portion decreases and this more patient can be diagnosed. Either they have absence of fibrosis or they have presence of advanced fibrosis. So these tests have high sensitivity and specificity while enabling the classification of large proportion of patients to be diagnosed and with or without advanced fibrosis. So this is the invasive test. It is not the gold standard, but the available gold standard. The problem is it is dependent on adequate biopsy size, the diagnosis. The biopsy of at least 2 to 3 centimeter length with 16 gauge in caliber is recommended. Presence of less than 11 Porter tracts in pathology report may be incorrect in recognition of the grading and staging due to insufficient sample size. Sampling error is common and it can be a problem for the diagnosis of fibrosis. The advantages of biopsy is that it makes the diagnosis of NASH. So you can make a treatment. Also, it stages the fibrosis if imaging or tests are indeterminate. Also, it rules out concomitant liver diseases like autoimmune, Wilson disease, drug-induced liver injury, and iron overload. So it is to be done in which patients we should go for liver biopsy. So now this is risk stratification in patients with suspected NAFLD. So again, fatty liver with raised ALT, you rule out alcohol consumption, you rule out other causes of raised ALT we just mentioned, and to confirm it is NAFLD. Then low risk profile like BMI is low, age less than 40, no metabolic risk factors like diabetes, dyslipidemia we just mentioned, and we estimate non-invasive fibrosis scores. They are all less than the predicted value, and FibroScan is also less than 7. It means low risk of fibrosis. These patients need to have a follow-up and reassess as risk factors evolve. Now, these are the patients which have intermediate risk profile. BMI is more than 29.9, high BMI, age more than 40, multiple features of metabolic syndrome like dyslipidemia, diabetes, and non-invasive fibrosis estimation is also in a range indeterminate, and FibroScan is between 7 to 9. Then these patients might need liver biopsy. Like the scenario which we had discussed initially, that patient had high BMI, that patient had metabolic risk factors. If we calculate these scores, they are in between. So that patient might be a candidate of liver biopsy. Then there is another high risk profile. This is very important. If AST becomes more than ALT and platelet is less than 150, thrombocytopenia with this NAFLD, so it is almost confirmed cirrhosis, advanced F4 fibrosis. Again, in these patients, non-invasive fibrosis score will be high. FIB4 is value of more than 2.6, APRI more than 1.5, and NFS more than 0.6. Again, FibroScan will be showing value of more than 9. So these are almost diagnosed case of cirrhosis. You can consider liver biopsy or other test, elastography, to confirm it, but it is cirrhosis. Our patient falls into this category. So what are the clinical predictors of NASH in patient with NAFLD? Patient who comes to you with fatty liver, what are the chances this patient might be having steatosis or inflammation? So advanced age, greater duration of disease, more chances of NASH. And post-menopausal women experience accelerated disease. It is high in Asian population, the risk of NASH. Again, metabolic risk factors, hypertension, obesity, dyslipidemia, diabetes, increased risk of fibrosis. We just mentioned that AST to ALT ratio of more than 1 and low platelets, indicator of NASH cirrhosis. Again, fatty liver with persistently elevated ALT, it can be associated with greater risk of disease progression. So what happens in NASH? There is mortality is increased. This is a patient which has NAFLD. This is the liver-related mortality, this blue color. When NAFLD changes to NASH, over the follow-up 13 years, it was seen that mortality, liver-related mortality is increased in NASH in comparison to just fatty liver without NASH. So regarding management, the most important and basic is lifestyle modification. This is the mainstay or cornerstone of the treatment. Then targeting components of metabolic syndrome, like we had seen the patient which has diabetes and dyslipidemia. So treat those, and along with hypertension, all these components. And then liver directed pharmacotherapy. And if patient has F4 fibrosis, that is called cirrhosis, then complications of the cirrhosis. So we start with lifestyle modification. This is when your life changes, your shape changes. So I think 3 important things are important. One is exercise for change. The other one is diet. And third one is motivation. This is very important for weight loss. अल्लाह ने जहन्नम भी बनाई है, जन्नत भी बनाई है. जन्नत उन लोगों के लिए जिनको शौक होता है कि हम अच्छी, उनको आप पॉजिटिव चीज़ें बताते हैं, benefits बताते हैं, they go for that. कुछ लोग ऐसे हैं उनको इससे ज़्यादा असर नहीं होता, they more commonly have a fear factor. तो उनके लिए अल्लाह ने जहन्नम बनाई है, उनको डर खौफ से डराया जाता है अच्छी चीज़ के लिए. So you can counsel these people positivity के आप, if you lose weight you will have these benefits, you will look good, you will have high self-esteem, everything, you will be more social, so they will go for, they will get motivated for that. There are other people, you make them a fearful thing, like you will have this obesity, you will have all these complications, diabetes, hypertension, liver related diseases, so they get motivated to avoid those complications. So diet, exercise and motivation, this is very important. So how to lose weight? This is the BMI of Caucasians who are Asians. So it is underweight people less than 18.5 kilogram per meter square. Normal range is 18.5 to 22.9, and our weight is 23 to 24.9. And now this is alarming, and obese definitely more than 25, they are obese. So these people are targeted, especially overweight people, if they have associated diabetes, hypertension and metabolic factors. So first thing is diet, change to low caloric and healthy diet. Other thing is exercise. So these two things are cornerstone for the weight loss. So hypocaloric diet plus moderate intensity exercise, it leads to sustained weight loss. People who have a low caloric diet but don't do exercise, less likely to have sustained weight loss. People who don't have diet, just exercise, again, less likely to have sustained weight loss. You need both of them to have weight loss. And there are a group of people which don't have low caloric diet, don't do exercise, and they expect miracles for weight loss. So both things are needed. So along with motivation. So the effect of weight loss, you see, if weight loss is 3%, the steatosis in case of non-alcoholic fatty liver disease, it improves. In weight loss is 5%, even inflammation improves. And if weight loss is 77%, NASH resolution is there. And if weight loss is more than 10%, even fibrosis gets regressed, like F3 may convert into F2, F2 may convert to F4. So weight loss is the cornerstone of the treatment. Again, this coffee, we should mention it because it has a lot of positive effects, like it decreases GGT, transaminases, decrease risk of type 2 diabetes, and decrease risk of cirrhosis and HCC in a lot of studies. So it can be recommended as a dietary measure. So what happens, the people with high weight, they do not respond to low caloric diet and lifestyle interventions, exercise. So they could be given that drugs for losing weight, especially if high weight with comorbids and high obesity. So these are the drugs which can be used on long-term basis, semaglutide, liraglutide, and these are the for short-term basis. In people who do not respond to this lifestyle modification, even drug therapy, then those people are candidates for endoscopic therapies for obesity. A balloon is placed in the stomach, so it keeps the feeling of full stomach. So people have anorexia and they eat less and they lose weight. Again, endoscopic sleeve gastroplasty, in which the volume of stomach is reduced. So patient can also opt for bariatric surgery if no response to drugs after life, no improvement with lifestyle modification. You see, with bariatric surgery improves clinical parameters a lot. In a study which was done, for example, ALT was before surgery was 30 and it was reduced to 22 after 5 years. So a lot of improvement in these values after bariatric surgery, along with diabetes and other parameters. This is a bit busy slide just to show you that with more than this one is if you see more than 5% weight loss, green one, and this light one is less than 4% weight loss. So all fibrosis score, NASH and other things, inflammation, they improve a lot with weight loss. And this is ALT, AST, GGT, they decrease a lot after 5% weight loss. And again, progression of cirrhosis is reduced with weight loss. So weight loss has a lot of positive effects on all these parameters. Now, pharmacological treatment of NASH, it is clear that no FDA approved therapies for NASH are present. Currently, two drugs are of proven efficacy. One is vitamin E, which is available with the name of Evion, 800 milligram per day, and the other one is pioglitazone, which is used in diabetes mellitus. So this vitamin E, non-alcoholic steatohepatitis without diabetes, it is recommended, and American guidelines also recommend it. And pioglitazone with or without diabetes can be used. Again, American guidelines, ASLD recommended. Metformin is not a drug used to be in NASH. But why vitamin E is not to be given in every patient? Because 50% of patients do not respond to vitamin E. Also, long-term safety of vitamin E is not known. It may have increased risk of hemorrhagic stroke or prostatic cancer risk. So this is again pioglitazone. American guidelines recommend it. May be used in patients with biopsy-proven NASH. And vitamin E again, ASLD recommends may be used in non-diabetic adults with biopsy-proven NASH. But in our setup, people don't go for biopsy. They're not willing. So in our setup, we can use it even without biopsy-proven NASH, if NASH is there through non-invasive tests. Now, examples of NASH treatments in phase 2 and phase 3 investigations would not go into detail, but there are drugs which may be of benefit in the future. Liraglutide, semaglutide, empagliflozin we just mentioned. They may be, initially they are of some benefit, we will see in the future. This obeticholic acid, again, one of the drugs. So now we come to the case scenario we just mentioned. You see this patient has obesity, raised ALT and fatty liver. So now I think you should be able to know how to proceed further. This patient needs non-invasive markers, FIB4, EPRI, nephral fibrosis score, FibroScan, and on the basis of this, along with this metabolic risk factors, he may fall into moderate category and may need liver biopsy. So take home points for the diagnosis: to differentiate NAFLD from NASH, use clinical parameters and non-invasive tests. We just mentioned serological and radiological. Non-invasive tests are reliable for exclusion of fibrosis, especially if exclusion of advanced fibrosis. Liver biopsy becomes necessary if ALT is persistently elevated and risk factors for fibrosis are present. And again, take home points for the management. Lifestyle changes are the cornerstone of the treatment. Weight loss of more than 3% up to 10% is associated with histological improvement in the non-alcoholic fatty liver disease. ASCD guidelines suggest that vitamin E, NASH without diabetes, and pioglitazone, NASH with or without diabetes, might be used. And then again, it recommends bariatric surgery. Preliminary evidence for improvement in fibrosis with some investigational therapy. Yeah. Thank you. Thank you, sir.
Thank you so much, Dr. Numan. There are so many questions, and after the few words, after Dr. Rubina Rafiq, I will ask the people who want to ask the question, they please raise the hand. So many questions have already been covered by Dr. Numan about vitamin E and causes, lifestyle. Anyhow, if anyone asks any question, he and she can raise the hand. Very, very senior teachers, our Jana Sahab, Assalamu alaikum, sir. Dr. Rubina Rafiq, General Aslam Sahab is also here. Professor Lagari is also here. Very senior teachers. Dr. Rubina Rafiq, it is over to you.
Assalamu alaikum. First, I would like to thank you, sir, to give me an opportunity to come on this forum in front of my seniors and my colleagues and my juniors. Dr. Numan has given a very good presentation today. Fatty liver and the problems related to it are too much common nowadays. One important thing I would like to add is whenever a patient of the fatty liver comes to us, the persons around him, that is a family of that person, is very important to find out further cases, because we know this hypertriglyceridemia, low HDL and pre-diabetes, these are usually genetic and they are running in the families. So what is our experience? Usually a patient who comes with fatty liver is not alone. This is usually a family of patients with fatty liver. So it will help us to screen further patients as well. And number two, if we are able to cover the family, we are able to cover their kitchen as well, because we know the adding factor is a lifestyle, if increased fatty foods and their taste towards the daily eating habits. We can cover it like if we counsel the family to change their dietary habits, we can easily cover not only that patient for the treatment, but the whole family. And of course, this is a very important point. Then we know that treatment mostly includes our lifestyle changes, our exercise and weight loss. And we have practically seen so many patients, if they are going to decrease their weight up to 10%, they have complete change of their life. And thank you, sir.
Thank you very much. Professor Amir, Brigadier Amir is there. I will ask the question from Dr. Amir, is a chemical pathologist also. Professor Amir, is there any role of the laboratory in early diagnosis of this NAFTL? Brigadier Amir? Sir, you can
Yes,
unmute.
sir. Thank you very much for
Thank you, sir. Thank you.
questions. Yes, I would say it is the laboratory, especially the biochemical tests,
Sure.
which first of all points out towards NAFLD. We give a lot of stress to ALT, alanine transminase. Please don't call it SGPT. It is not SGPT, it is ALT. This is, I tell you, many times we just found isolated rise of ALT. And when we got their other biochemical tests, for example, glucose or lipids, they were also raised. Then we got ultrasound done, and ultimately it found it was NAFLD. So I think we are the first person. I mean, the biochemical tests, they are the pioneer in diagnosing it. It was an excellent presentation by Dr. Numan. I really learned a lot from it, especially the indices were excellent. Just to add some knowledge, there are some new markers also for fibrosis. Not very new. We published on hyaluronic acid about in 2006, and it is available. It is said to be a biochemical marker for fibrosis. Now, there are some other tests added in this battery for, I don't say that they are very reliable, but they are open to research and we can get these tests done. They are now available on chemiluminescence also, CLIA, and we can carry out a research project or we can use in practice. I will share these the list to you in my post in the group, and this was an excellent thing. Just one small.
Amir, you can
small...
share it on the chat, and you can also share me here, and I will upload this to the all audience.
Okay.
Yes, that is
just
why
one very small correction.
So many new.
These are not serological tests.
Yes.
They should be called biochemical tests. When we
Yes.
say serological tests, they are mostly antibodies. So this MAFLD is not an autoimmune disorder. There is absolutely no role of serological tests in it. So we should call it biochemical tests. Thank you very much.
Thank you very much, General Aslam Sahab. You are teachers of the teachers. Can you comment few things on this fatty liver disease?
Sir, thank you very much.
Thank you, sir.
Rather than commenting on it, my question to Dr. Numan will be,
Yes, sir.
how does hepatitis B, are people with hepatitis B more prone to have fatty liver, or it is the fatty liver which leads to hepatitis B?
Hepatitis B basically can lead to fibrosis, cirrhosis and fibrosis basically.
Right.
Thank you so much, sir. Dr. Rashid, you have raised the question and you have asked so many questions. Over to you, Dr. Rashid Sahab, Professor of Physiology.
Yes, thank you very much. First, Dr. Numan, an excellent presentation. You have made the things very simple who are not gastroenterologists. बहुत शुक्रिया आपका. क्वेश्चन इज के डू वी नीड रेगुलर स्क्रीनिंग और क्या इंडिकेशन है और कितने अरसे बाद करनी चाहिए कि क्योंकि वी आर वरीड अबाउट आवरसेल्फ और फैमिली एंड पेशेंट, तो इसकी स्क्रीनिंग के बारे में बताएं कि कब करनी चाहिए, और उसके बाद एक दो क्वेश्चन मैं और भी पूछूंगा।
LFTs तो सर एक वंस और एक दफा तो सबका होना चाहिए, an ultrasound especially, because these are the two tests which can give you an indication that you might be having fatty liver disease.
कितने अरसे बाद?
Raised LFTs, raised ALT and AST. So once जिसका आ जाए तो फिर उसका further workup.
नहीं, अगर किसी का नॉर्मल आता है तो कितने अरसे बाद दोबारा कराएं? हर 2 साल बाद, साल बाद, 3 साल बाद?
अगर वो एडवांस में नहीं है, वो जो रिस्क फैक्टर हमने डिसाइड किए थे कि माइल्ड रिस्क है जिसमें कोई मेटाबॉलिक फैक्टर्स नहीं है, चीजें ठीक हैं, तो उसमें आप 3 to 4 years की बात करते हैं। जिसमें फाइब्रोसिस आ जाती है उसमें मोर फ्रीक्वेंटली।
राइट। नवाज साहब, कुछ मेडिसिन है यूज हो रही हैं, प्रमोट हो रही हैं, लाइक कैप्सूल, रोवाकॉल, ट्राइकार्डिन, रिवोलिक और ग्लूकोफेज देते हैं, स्टेटिन्स देते हैं, इनके बारे में कुछ कमेंट करेंगे?
अभी मेंशन किया था ना मेटफॉर्मिन जो ग्लूकोफेज है या एटर्वास्टेटिन है, दे हैव नो
रोड। और ये रोवाकॉल, ट्राइकार्डिन, रिवोलिक, ये कुछ मेडिसिन है,
हाँ, सॉर्ट ऑफ प्लेसिबो इफेक्ट, गाइडलाइन में किसी का भी कोई रोल इसमें नहीं है।
गाइडलाइन में इनमें किसी का नहीं है। राइट, थैंक यू वेरी मच।
Thank you very much, Dr. Mahanur Khan. Dr. Mahanur Khan. Dr. Mahanur Khan, you can unmute. I have allowed you. Okay, Dr. Madam Salwa Kundi, आप सवाल पूछे मैडम।
Assalamu alaikum. I'm so happy to see such familiar faces over here. Great people around me like General Aslamia, Rashid Saab, Brigadier Amir Ijaz, Rafiqul Hassan, our brother, Professor Laghari Saab, and of course seeing you, Professor Mulazim Saab, is always a pleasure. Everybody on this forum. I take this opportunity of asking Dr. Noman that if somebody gets cirrhosis, can this disease be reversed or do they need liver transplant? That is the end
हैंड रेज किया था, उन्होंने मेरा नाम भी बोला और मैंने
अपना बोला है आपको मैडम, आपका इसके बाद आपको इजाजत है मैडम, आपको बोला है, आपको मैं माइक नहीं हो रहा था। नेक्स्ट टाइम आई विल अलाउ।
May I answer the question first?
Yes, please, Noman sir.
मैडम ये जो we just mentioned कि lifestyle modification या weight loss, even fibrosis can be reverted. So patient who have developed cirrhosis which is compensated, so things can be controlled and even reversed with lifestyle modification. But again they need to be screened for HCC क्योंकि एक दफा cirrhosis हो जाए तो risk of HCC hepatoma is there. So उनका regular follow up or follow up for complication is needed all the time. But it can
please tell me what ACC is? Because I'm not a gastroenterologist.
Sorry, what?
Terminology.
What is ACC?
Explain the terminology.
HCC, hepatocellular carcinoma, tumor of the liver, which is the
HCC. Okay. Okay. Thank you.
Gigi and Dr. Noman, you were giving the answer.
Sir, these are it can be reverted as far as fibrosis is concerned, even compensated cirrhosis may. But once decompensation is there, like varices, upper GI bleed, ascites, encephalopathy, so if patient becomes candidate of liver transplant, so he may go for that. Before that, compensated cirrhosis, things can be reversed with lifestyle modification.
Thank you, sir.
Dr. Mahanur Khan, you have raised the question. Dr. Mahanur Khan.
Yes, Assalamu alaikum.
Walaikum assalam.
My name is Dr. Mahanur Khan. I'm from Lahore, Sheikh Zayed Hospital. I work here as an assistant professor. I just wanted to ask Dr. Noman that me myself, I am facing non-alcoholic fatty liver disease since the last year, and my LFTs are slightly raised only, and it was diagnosed on ultrasound grade 1. But I want to just ask you that because I had gone cholecystectomy almost 10 years ago, and I feel that my fat is not being digested properly. Hello? Ji, can you hear me?
आवाज आ रही है डॉक्टर महानूर, आ रही है मेरे बेटे, आ रही है आवाज।
Ji, ji. So I just wanted to ask that does this having a surgery, having the surgery of cholecystectomy can also affect or can also increase the chances of NAFLD? And if it's true, then do we certainly should take bile salts with our diet or not? Because no doctor recommended me any bile salts whatsoever till now. But I feel that maybe that could be a reason, because I have no family history, and maybe a diet could be a factor, but I don't think that my diet was very different from what my other family members were eating. But I am facing a mild degree of fatty liver disease. So do you think that cholecystectomy is a factor in developing this disease? And if yes, what is the solution?
It's not associated.
Madam, इससे पहले before this, can I ask, give the answer to Dr. Mahanur? Dr. Mahanur, myself has cholecystectomy was done in 1985 when I was a final year student. But still, my liver is excellent and has not anything. And the basic thing is that I have adopted the 7 things that Dr. Nouman told me and told in this presentation: your lifestyle, your diet, and everything. I do not think cholecystectomy can precipitate an fatty liver disease. Dr. Nouman, what can you say?
Right, sir. It is not associated with that.
Yes, it is not associated with. Any other question, Dr. Mahanur?
No, thank you. Jazakallah.
Okay, thank you. There are so many compliments to Dr. Rubina Rafiq. It's very special about the family, and very compliment to Dr. Nouman. And Dr. Iqbal, you asked the question. Dr. Iqbal Sahab is there. Dr. Iqbal Hussain, you have asked the question about the vitamin, but Dr. Nouman has already explained about the role of the vitamin E. So many other questions. Ji, Dr. Iqbal.
My question was, Assalamu alaikum to everyone. Sir, my question was just to the best treatment is still alive. The fatty liver, if there is no hyperlipidemia.
Sorry, sir.
Patient with obesity, a patient with obesity and having no hyperlipidemia.
Sir, fatty liver में then you calculate the score. Test. FP score, FIB score, and NFS आप निकाल लें. Then remains the weight loss, lifestyle modification.
Need investigation are not available in everywhere. I think that we can do.
Net का issue आ रहा है आवाज का.
Dr. Iqbal, दोबारा सवाल पूछे. We cannot understand the question. Can you ask the question again?
My question. Are you hearing me, Dr. Nouman?
Yes, now we can hear you clearly.
Sir, my question is: a patient having just fatty liver, as I'm doing ultrasound here, and a normal having no hyperlipidemia. So what can be treated for them? Are just taking diet and exercise?
Judging of the liver disease is like
sustain or Sembex, like is eating Sembex tablets है या sustain को हम दे सकते हैं उसके लिए for a week or 3 weeks or 1 month.
ALT आप कर लें, वो रेस्ट है. बायोकेमिकल मार्कर्स कैलकुलेट कर लें, स्कोरिंग सिस्टम F3, F4, NFS बताया था आपको. Otherwise, lifestyle modification is enough. If
I was 10-15 minutes late in the lecture.
Vitamin E आप
vitamin के role आ गया, very good role. And even Dr. Professor Ayub Saab has asked a similar question about the vitamin E, and you have, can you elaborate again on vitamin E? So many questions are asking again, vitamin E. Given on short-term basis, guideline में तो mention है कि it should be given in biopsy-proven NASH. But in our we cannot do biopsy, so we give it without biopsy. So it can be given in short-term basis, but long-term safety is not clear. So long-term नहीं देनी चाहिए, short-term आप दे सकते हैं, and then can monitor the response. One question to you, Dr. Rubina Rafiq. What is the role of family history? You mentioned one question is to you, asked by Dr. Usman, I think. Dr. Rubina Rafiq.
Yes, sir. Yes, sir. Are you listening me?
Yes, yes.
Family history is very much important because you see the history of triglycerides. If triglycerides are raised, they run in the families. And you see, if there is diabetes, usually it runs in families. If a member is diabetic, we have to ask about other. We can found others may be in pre-diabetes state. So family history becomes important. And that this is one aspect that genetics wise, the other that is our living together is also important, because living together means using single kitchen. Single kitchen means using same diet. So we are asking for their family living in social gathering. We are asking about the diet pattern. So family history is important in two ways. And second, if you allow me, I would like to add one comment. Sir?
Yes.
We have not discussed up till now about young females who are coming with history of menstrual irregularities, and they have polycystic kidney ovary disease. और अगर हम in the long run देखें तो polycystic ovary diseases जो हैं ये भी basically आपके जो हैं वो जो है उसी के साथ related होती हैं in the long term, metabolic syndrome के साथ. और ये वो वाली patients होती हैं जो in the long run सारी complications early age में develop करती हैं.
Excellent, very important point.
तो मेरी ये रिक्वेस्ट है कि जब भी हमारे पास ये पेशेंट्स आती हैं तो वी शुड उनको स्क्रीन करना चाहिए और उनको काउंसल करना चाहिए लाइफस्टाइल मॉडिफिकेशन फॉर देयर होल लाइफ.
थैंक यू. अच्छा, एक और क्वेश्चन है कि फैटी लिवर विदाउट हाइपरलिपिडेमिया हो सकता है?
जी बिल्कुल. देखिए हमने जब बात की मेटाबॉलिक सिंड्रोम की तो फैट उसमें हाइपरट्राइग्लिसरीडीमिया उसका एक कंपोनेंट है. उसमें वेस्ट हिप सर्कमफ्रेंस से ओबेसिटी के लिए बीएमआई और दूसरा हमने कैलकुलेटर यूज किया. फिर हमने प्री डायबिटीज या डायबिटीज या इंसुलिन रेजिस्टेंस के लिए यूज किया. तो अगर उसमें एक ट्राइग्लिसराइड नहीं है तो बाकी कंपोनेंट्स तो हो सकते हैं ना. तो हमें वो उन बाकी कंपोनेंट्स को भी जो है एड्रेस करना है और उनको भी ट्रीट करना है.
जी डॉक्टर नुमान, एक क्वेश्चन है आपसे कि कैन वी रिवर्स द सिरोसिस एंड एट व्हाट ग्रेडिंग level we can reverse the cirrhosis, because it is very important topic.
Cirrhosis compensated means patient has not developed ascites, encephalopathy.
What do you mean by compensated?
Means no complication of cirrhosis, like no ascites,
no complication of cirrhosis,
no ACC and no encephalopathy. So this can be this progression can be reversed a bit with weight loss just mentioned. F4 may be changed to F3 or F2, but once decompensation it may progress.
ठीक है. अच्छा, एक सवाल है जो मुझे मेरे पास जो आखिरी सवाल है पूछा गया है, इसके अलावा अगर किसी ने पूछना हो तो बता दें. वो व्हाट इज द इंडिकेशन ऑफ स्क्रीनिंग?
Ideally, every patient should be screened for hepatitis B and C and LF disease at least once in their life. Metabolic factors like diabetes, obesity, hypertension, dyslipidemia, these are there, then these patients have more chances of having non-alcoholic fatty liver disease, especially obese patients.
सही. एक तिफलाना सा क्वेश्चन है, चाइल्डिश सा क्वेश्चन है. Have you seen any fatty liver diseases after COVID? Because yesterday we were in a webinar, and in a USA webinar, she was presenting and she was telling us that the COVID has decreased the expectancy of the life in many ways. And she also mentioned the involvement of the liver. Can you comment on it?
I think we need more research on that, whether the patient has fatty liver, it is developed because of the COVID or it was present before. Developed after the COVID, definitely it needs to be researched. For research purposes हम कर सकते हैं. Apparently अभी तक कोई ऐसा fatty onset after COVID ऐसा देखा नहीं है. Might be, it might not be.
Yes, because she was telling that the long COVID, one of the important factors, there are so many factors, and even the corona can live in the liver and in the endothelial areas for a long time. Okay, thank you very much. Anybody can give the comment, and if there is no comment or no answer, I will request Professor Salma Kundi to conclude today's session. But
सर एक छोटा सा आपको खाने के लिए कहना है। लगता है कि आप मुजफ्फराबाद में नहीं है, बहामास में हॉलीडेज मना रहे हैं।
मैं सर नहीं सर, एक्चुअली बेसिकली वी आर इन फ्लड एरियाज।
आपका बैकग्राउंड बड़ा खूबसूरत है
सर। मुजफ्फराबाद मेडिकल कॉलेज इज serving giving the services in the Dera Ghazi Khan areas and in the
नहीं, आपका बैकग्राउंड देखें ना सर,
in the Rajanpur सर।
बैकग्राउंड में वो है
सर, ये प्रोफेसर अयूब साहब को अपनी फैकल्टी को छुपाने के लिए कि मैं कहाँ बैठा हूँ।
सर चूंकि आप इस वक्त एक
खास तौर पे अयूब साहब से
बैठे हैं, यस सर, तो इसलिए हमें अपना वो छुपाना पड़ता है कि हम कहाँ बैठे हुए हैं। ये हमारी पेशा वाराना जरूरत है।
Thank you so much. Thank you so much, Doctor. It was really very interesting and very learning, and I myself learned so many things. And very senior, my teachers, my friends are there. I'm very thankful to all. And I request Professor Salma Kundi, and we all are praying, Dr. Salma Kundi, for a good health of your mother. Allah Ta'ala unko shifa de. Allah Ta'ala unki umar daraz करे और Allah Ta'ala पाकिस्तान पूरे के मसाइल हल करे। डॉक्टर सलमा कुंदी, over to you.
Ameen. Thank you so much, Professor Mulazim sir. I take this opportunity of thanking everyone here, especially Dr. Noman Kareem Qureshi, for his lovely talk. On behalf of Pakistan Medical Association, Pakistan Physiological Society, Pakistan Association of Pathologists, and Azad Jammu Kashmir, the Muzaffarabad Medical College, jinke hamare pyare bhai principal hain, and of course Women Medical College as well. Thank you everyone who's attended it. It's always a pleasure. These webinars are a success because of you. And Dr. Mulazim gives us such lovely learning opportunities. I too have a fatty liver. और मेरे तो पहले सिर्फ ट्राइग्लिसराइड्स रेस थे, अब कुछ अरसे से एलटी भी हो रहे हैं, तो मैं फिक्रमंद हो गई हूँ। That means कि मुझे weight loss के ऊपर अभी काम करना है इंशाल्लाह ताला। Thank you for saving my life, Dr. Noman, वरना मुझे ये नहीं पता था कि it can easily lead to cirrhosis. I was sleeping on it. And I hope it saves all our lives. और ये जो भी सुनेगा, क्योंकि हम इसको फिर अपलोड भी करते हैं, मुलाजिम साहब अपने वेबसाइट पे लगाते हैं, हम PMA के वेबसाइट पे लगाते हैं, so everybody can have a look at it and listen to it. डॉक्टर उस्मान अंसर ने लिखा है कि जीपीस को इसमें इन्वॉल्व होना चाहिए। अब मसला यूं है कि हम तो ये फ्लोट कर देते हैं व्हाट्सएप ग्रुप्स में, हमारे पास कोई जीपीस का व्हाट्सएप ग्रुप नहीं है। पीएमए की तरफ पे मैं फ्लोट कर देती हूँ।
ग्रुप नहीं है जी आपका।
मैं ऐड करता हूँ जीपीस का, हमारी है
पाकिस्तान
फैमिली है, मैं उसका लोकल प्रेसिडेंट हूँ, तो वो मैं कोऑर्डिनेट कर दूंगा।
हाँ प्लीज आप उसको वहीं पे फॉरवर्ड कर दिया कीजिए।
मैं कर दूंगा, मैं उनका लोकल प्रेसिडेंट हूँ, तो मैं कर दूंगा इंशाल्लाह ताला।
ठीक है, डॉक्टर करीम भी बैठे हैं, प्रोफेसर करीम भी बैठे हैं, वो भी कर देंगे जी। डॉक्टर सुहेल, आपने आखिर में सवाल हाथ खड़ा किया, यू आर अलाउड टू आस्क द क्वेश्चन। लेकिन एक मिनट, मैडम सलमा कुंदी, मेरी तरफ से आपको दावत है, और आपका जो एक प्रोफेसर ऑफ बायोकेमिस्ट्री आ रहा है, उसे कहें जी वेलकम। हम उसको अपने पास ठहराएंगे और उससे किराया पे। डॉक्टर अयूब, किराया नहीं लेना आपने। डॉक्टर अयूब साहब, डॉक्टर करीम साहब,
थैंक यू सो मच, थैंक यू सो मच। मैं सर आंखों पे आती, लेकिन जरा अम्मा की वजह से
पास ठहराना है
जी सर, अकोमोडेट हो जाएंगे सर इंशाल्लाह सारे मेहमान।
अच्छा जी, डॉक्टर सुहेल, यू आस्क द क्वेश्चन, एवरीबॉडी इज वेलकम सिंपोजियम जी। डॉक्टर सुहेल खान राजा, आवर यंगेस्ट पल्मोनोलॉजिस्ट,
अस्सलाम वालेकुम,
मेडिकल कॉलेज जी। सुहेल राजा,
अस्सलाम वालेकुम सर, अपॉलॉजीज अगर आवाज ना आए, मैं गांव में हूँ, थोड़ा सिग्नल बारिश भी है, तो सर डॉक्टर नमान करीम कुरैशी ने एक्सीलेंट मैसेज दिया है। चूंकि ये मेटाबॉलिक सिंड्रोम का पार्ट है, तो हमारे सामने सर 30-40% मसला है हमारी डॉक्टर कम्युनिटी का भी। मेरी सर बीइंग आप टीचर्स बैठे हैं, सारे पॉलिसी मेकर्स बैठे हैं, एक रिक्वेस्ट है कि जो हम हमें एजुकेट करने की, चूंकि ये मेटाबॉलिक सिंड्रोम है, इसको प्रिवेंट करना ही असल इसकी ट्रीटमेंट है कि वेट गेन तो इसमें सर एक ये मेरी रिक्वेस्ट है कि जो हम खाना खाते हैं नॉर्मली, उसमें हमें जो कैलोरीज इंफॉर्मेशन होनी चाहिए हमारी मैसेज को, कि जो एक प्लेट ले रहे हैं उसमें कितनी कैलोरीज ले रहे हैं, जितने एक्स्ट्रा वो कार्बोहाइड्रेट लेंगे वो फिर ये सारे मसाइल आगे करते हैं। तो इसको प्राइमरी इंटरवेंशन इसकी हमें इसकी प्रिवेंशन की तरफ इसको एक तहरीक की सूरत में इसको करना चाहिए, चूंकि डायबिटीज, हाइपरटेंशन, हार्ट डिजीजेज, ऑब्स्ट्रक्टिव स्लीप एपनिया, ये फैटी लिवर, ये सारा स्पेक्ट्रम ऑफ वन डिजीज है। तो हमें इसको जरा सर टेकअप करना चाहिए अर्ली लेवल पे, ताकि चीजों को प्रिवेंट किया जा सके।
Sure. Thank you so much, madam. Can you allow to conclude today's session, Professor Salman Kundi? जी मैडम, आपका वो
Hello.
रह गया था जी।
Thank you everyone who attended this, and thank you Dr. Nouman Karim Qureshi. It was a lovely talk. It was really worth it, and I hope you all have a good Sunday. Allah आप सबको अपनी हिफ्ज़-ओ-मान में रखे, अल्लाह पाकिस्तान का हामी और नासिर रहे, और मेरी वालिदा के लिए प्लीज दुआ करें, अल्लाह उनको आसानियां दें। Thank you so much. Allah Hafiz.
Ameen.
Allah Hafiz. Allah Hafiz. Allah Hafiz. See you
Allah
next
Hafiz.
time.
Everyone from Balochistan.
Allah Hafiz ji, thank you.
फिर कानी साहब, Allah Hafiz. Allah Hafiz. हाफिज करीम साहब, डॉक्टर अयूब साहब, अल्लाह हाफिज। अल्लाह हाफिज। डॉक्टर लगारी साहब, अल्लाह हाफिज। अल्लाह हाफिज। आज तो हिना ताहिर भी आई हुए, अल्लाह हाफिज।
थैंक यू सर, थैंक यू, अल्लाह हाफिज।
डॉक्टर आरिफ साहब,
थैंक यू
अल्लाह
सर, थैंक यू सर, थैंक यू।
Naman, thank you very much. Dr. Rubina Rafiq, thank you very much. You presented with this presentation with a short notice, on a short notice. Thank you so much.
वेलकम सर।
बहुत अच्छा था, हाँ कमाल का था माशाल्लाह।
आपका थैंक यू सर, बहुत ज्यादा।
हमारी एक्सपेक्टेशन से भी आपने ज्यादा अच्छा प्रेजेंट किया, बहुत अच्छा। थैंक यू। अस्सलाम वालेकुम। आबिद करीम साहब कुछ बोल रहे हैं आप? मियां रशीद साहब, थैंक यू सो मच सर। प्रोफेसर मियां रफीक साहब,
थैंक यू सर।
थैंक यू सर। थैंक आपकी अल्लाह सेहत दे। कैसी है तबीयत सर?
काफी बेहतर हूँ सर, दुआ करें।
वो एक हफ्ता रह गया आपका, एक संडे आपने करना है
इंशाअल्लाह, इंशाअल्लाह।
हाँ, थैंक यू सो मच। अस्सलाम वालेकुम।
थैंक यू।